Okay, so there's 25 of us. I think everybody might have moved over now. Do you want to start, Joel? Off you go.
But you're going to give me a nice introduction there.
Oh, sorry. Would you like me to introduce you? You can introduce yourself, Joel. Come on.
You're building up.
Yeah.
Hi, everybody. Can I just check, Leslie, can you see that screen? Non-medical prescribing cover. Has that now appeared for everybody?
Certainly can, Joel. Thank you.
Wonderful. Hi, everybody. My name is Joel Hannon. I'm interface pharmacist and commissioning pharmacist at Bolton CCG. One of my roles is as our NMP lead for the CCG. I like to be interrupted as much as possible during presentations, so you can use the chat, you can shout out, hands up, anything like that. Please ask any questions as often as you want. Can't say that I'll have all the answers straight away. I can certainly take any away and come back if I don't have them. Just as a first off, have we got anybody who is absolutely brand new to non-medical prescribing on the call? Whatever you fancy, hands up, put your video on, a yes or a no in a chat if anybody does. Wonderful. At least I know a couple of people are out there, so you can hear me. Great. So this is, it works at any point when you qualify or after qualification. Lots of people see that non-medical prescribing is very much like driving test. You pass it, then you forget about 10 to 2 for the hands, you forget about what the highway code says, and you just carry on. I know we're all far too perfect to do that, but it's got that sort of feeling to it. So part of this is just, this is for day one, but it's also is reviewing what you do past day one and 10, 20 years down the line, up to whenever you decide to hang up your prescription pads. At which point the screen doesn't kick on, that's better. So today, just a bit of a cover. After this event, we'll be sending out a PDF document that we've developed with Salford University and also Bolton CCG, just about that starting for prescribing. It is a big bulky document. There is a lot there. It does go a lot into what you actually need to think about, the really practical side of things. So there is a lot of detail. I've just picked out the key things that I think they're in there, the most common questions, but also you'll get that in-depth information afterwards. There'll be a bit about maintaining your prescribing, how to review it, when you decide to change, what you need to think about those things, how you evidence what you're doing, always really, really difficult, and simple steps you can take to achieve these, and just simple things to think about. Again, if it's too simplistic, pop a message in the chat, put your hand up, say you need more detail, but I've just tried to cover this for everybody. So before you begin prescribing, again, usually I have to cover all the different areas that prescribe, but with this being primarily for nurses, your NMC registration is key. You can check there, it's publicly available, as long as you know either your PIN or your name, or your colleagues you can check up on. If you're a manager, you can go onto the NMC reg and see if somebody's got that qualification for prescribing. Also, once you qualify, the day that you actually get that certificate through, it doesn't mean you can prescribe from then, because everybody will review whether you're on the NMC register as a prescriber. That means that they have accepted that you can prescribe. So that is the key bit that starts everything off. So you can tell them you've got your prescription, the link's there on the screen. Often people think that magically it will happen behind the scenes and wonder why 6 months after they've finished their course and got their certificate, it's still not appearing, they're still not allowed to prescribe. So that's the first really simple step. The next two come together. So speaking to your manager, and this is something I'll keep coming back, and I'm sure you do with anyone who's describing about being a prescriber. You have much more responsibility as a prescriber in everything that you do, whether you're prescribing, whether you're reviewing medication, anything that you have interacting with anybody, you now have a proven knowledge and awareness above, you know, whether it's your nursing colleagues who aren't prescribers, whether it's a pharmacist who's not a prescriber, whether it's a health care professional who's a prescriber, there is added weight of responsibility. So equally, that means there's an added weight on your manager. So part of your annual reviews, part of your checkups, making sure that you have done everything you need to do as a non-medical prescriber to evidence your quality and your ability. All of that your manager now needs to support you on. So that first conversation, your manager will have signed you off, but then it's It's like pets. They're not just for Christmas. You know, study time support is not just for doing your NMP course, it's for life. The next is talking to your NMP lead. And so with this, really, really good if you have that ongoing conversation. If you're based within a trust or employed within a trust, that normally goes on continuously because the funding usually comes from that trust. And it's absolutely key for you to consider, right, actually, you've just invested £1,600 to £2,000 on a training course, allowed me to attend the course, allowed me support, allowed me to get in with prescribers. They're going to want you to be a prescriber usually as soon as you possibly can do. So they're all over you often. If it's a CCG lead, it's a bit different. The responsibility is the employer. So often it's your practice or your PCN. But again, that sort of support and governance, what's expected of you, what are the local policies, how do you go about what you do, what do you do at university if you have some problems? Again, you know, dropping out, not being able to do the study time, life gets in the way, can I put it off? Again, that local CCG lead is always good, but really simple things, getting onto your GP system, how do you get it to allow you to prescribe? How do you prescribe safely on EPS? So when you're sending out an electronic prescription, how do you review your prescribing? All of those things, your CCG NMP lead can help. Often really easy. If you're in a big practice and you've got hundreds of NMPs around you, they've got experience, they'll know how to do it. So you may not have to ask their help. It may simply be your manager, but that support's always there. And the last bit, I've probably put these words in a bit inappropriately with fitness to practice issues or concerns. It's again, that I'm trying to sort of suggest that actually you're going to be a prescriber. There's more responsibility. So actually, are you able to take that on? Do you have any challenges that you found with prescribing? Is there anything going on that you need extra support with? Because again, once you have that added responsibility, sadly as well, you also have access to medicines. So as a prescriber, you can prescribe. We know that people can misuse that quite easily, especially when they're in a very, very difficult place. So again, it's at that point, the responsibility from the NMC, from all of the guidelines that are out there is actually, unfortunately, you're asked to shout first. And I know the system should be better around support. And I know part of this is about producing support. But with that, it's about that thought, right, am I happy prescribing where I am? You know, actually, do I think there's a challenge? I've come across many NMPs who've gone through with a practice and thought, I don't really feel safe within this practice because I know what should happen and I know what I'm being asked to happen. And the two in my mind don't add up. So it's at that point, those challenges, those shouts for help, it should come at any time, but it's a really good sort of point to say, right, I'm going into prescribing here. Is this safe? Is this appropriate? So that's before you begin. There's a load more other steps in there. So getting onto your GP system, you know, actually being aware of how you prescribe, making sure that you actually trial your prescriptions. So, you know, when you are seeing the patient, the worst thing is that first patient, you tell them what drug you're going to give and then you can't find it on the system, or you can't get the printer to print, or you send the prescription and you're not sure where it's gone to. So all of those, trialing those basic things that I'm sure all of you have been through, pestering your practice manager, pestering your colleagues to make sure you run a few dry runs to make sure everything's absolutely fine. Again, that comes usually when you sign on. One of our key things that we found most useful in Bolton is when we send out what your prescription should look like. So as a nurse prescriber, it should have across the top that you are a nurse prescriber. So you know the system's been set up appropriately. Again, for us within GP land, prescribing digitally is always the way to go because you have the backup of the system, you have the backup of the computer, making sure that it reads correctly. So if you're doing anything that needs any special annotation, it prompts you, but also it records it far better than any paper-based system. So that's a before you begin. I'm really off put by the fact that everybody's got their cameras off. So at least I see some faces. So if anybody's rolling eyes at the moment or feels that this isn't going well or needs to be different, please put something in the messages because otherwise I feel like I'm talking to myself. Thank you. Next step is safe and effective prescribing. So for me, I'm a pharmacist by background. I eat, sleep and dream about prescribing and about safety. Thank you, Rebecca. I always like a positive comment in the task as well. So with this, safe and effective to me just means that you're challenging what you do. no one's eternally brilliant. No one's never going to get a wrong idea. No one's ever going to prescribe something and then turn around the next day and think, was that right? All of those things should be natural and things that you encourage in yourself. So how you do that is going to be very, very personal. But for me, once you've gone through your course, you sit at the university, you've got a wonderful P formulary, you've got a wonderful training package. For those who've got the videos on, would you say a book around about sort of that size that you filled in with your personal experiences and everything else like that? I'd be interested if everybody was confident enough to say that continues on into practice. I've got a few I've got people being honest on the video. This is wonderful. So with this, the safest way is to continue it. But in reality, you're not going to have 1,800 pages on each time you decide to add in a different paracetamol formulary into your P formulary. We know this. This is about reality. Now, some of your NMP leads might actually disagree with me and might say, no, we need this. We need the 1,800 pages on everything that's going to go in for this. So again, that conversation with your NMP lead about what's expected. But for me, it's about, right, how do I take that and make that into real life? And so your own practice, where you work, if you're a non-medical prescribing or a prescriber on a respiratory ward, you might only need 6 inhalers. And that is everything that's ever on your P formulary. And when one gets stopped, you might take that off and you might only have 6. If you're an experienced primary care prescriber, you might find it just balloons, and your experience and your capacity and the number of different lines and options just from a hypertension clinic, straight away you're talking about 30 products straight away. Diabetes, you're adding on another 60 to 90. So how do you manage to do that in the real terms so you can bring that through? And I put this, again, I would love to say that the Royal Pharmaceutical Society have done what everybody can use. They haven't, because all of us are such different in how we approach things, but they were commissioned to bring together a prescribing competency framework. So if you haven't seen this, I really hope you've seen some sort of form of this, but it has been updated in 2022. So there is a new one there and has what it suggests should happen to every single prescriber. So as a starting point, it's a really good place to go to. Again, there's lots of points there, which makes it look really, really that you're going to die in bureaucracy. And as a pharmacist, pharmacists love points. They love going and absolutely going over every single point more than is necessary. But again, it gives you the flavour to go to. So if you're trying to use this, don't get bogged down by, right, there's 100 lines here. Get bogged down with actually, right, what is it asking me to do? And just before I go into some of the bureaucratic, I thought I'd put a bit more into what comments people come back to. So if you are a prescriber, these are some of the common things that absolutely make my blood boil and suggest that you're not challenging yourself enough. So why have you made a prescribing choice? I've always done it that way. Never good enough. I think the longest standing meaningful guidance that's out there is for depression, which NICE updated in 2009. So, that means actually always in depression has only lasted 14 years. And again, it's looking a bit creaky now. But if you're looking at diabetes, I've always done it this way. We've had 5 updates in that period. So over the last 10 years, we've had 5 NICE updates. When you add in the guidance that they're now bringing with what you would consider diabetes medications now being used in heart failure, now being used in CKD, actually, if you say I've always done it this way, you're ignoring what's changed. Another great one, I always knew, insert whichever staff grade senior, whether it was your favourite nurse, whether it was your favourite consultant, has always used this. Again, they've got a different experience, different competence to you. It's not a good one. How dare you ask me? Don't you know what I am? That's really another common one. I don't know why I choose it. That's really brutally honest. You'll get many people who say, well, I probably knew 5 years ago, but now it just goes together. But again, challenging yourself can really help. So if that's one of your responses, why you're using it, really good to look at. Another one, prescribing is more art than science. Health is about grey and you're asking for blacks and whites. But again, this is right, why? What are you adding into this? The patient asks me to do it, or it's the only antibiotic that works for them. Again, proves that you're not supporting it. Should be the right choice for the patient, taking into account what they want, what they need, not just using that in place. And the computer didn't tell me not to. Again, We try and put prompts on computer systems to help. It's not universal. It never will be. You can't pull enough data out of that information to make a computer replace you. So if the computer doesn't say no, it could just be because people like me that write guidance have thought nobody's silly enough to decide to do this. So I don't need to put guidance out there. So again, a non-negative isn't a reason to go along with it. So those are some of my just slight points. If you fit into any of those, please go away, have a look at the medicine. There's always evidence there. There's always support for why you're making the right choice. And to check to see which choices you're making. Again, it's quite interesting when you ask people what they use, what they favour. Often it doesn't add up with their prescribing actual reality. So they'll say, well, my favourite drug is always Ramipril, and you find out actually they very rarely use it. It's the first one they think of, and they decide to use other things. So the simplest option is an audit. Everybody says audits are out there, but it can be something as really simple as just basically a page with what indication, you know, am I recommending here, who's it for, and why. And so you just do that for a day, maybe the same day each month, right? What am I going out there? Well, actually, I've started using a lot of drug X. Do I need to check out that I know this and I'm up to date? Is that what I'd expect? Am I being swayed one way? Have I just got used to giving something? But again, an audit can be as simple as you possibly want it to do. So just write, these are the 10 drugs that I most often use, do a tally chart. How many times have I prescribed them this month? Right, you know, I know where I'm up to. I'm prescribing within my P formulary, my competence, or actually just keeping an audit of what's outside of the normal. You know, what do you get asked at 5:30 on a Friday when the GP's got a queue outside of their room and you're asked if you can help? It can be really, really simple. It can be as complex as you want to. If you're doing a very narrow specific area, you can record, you know, actually respiratory patient, were they COPD or were they asthma? Did I do all of the things out there? How good was their inhaler use? You know, all of these things you can go through. Have I checked everything that I should have done? And if you're in GP land and you've got a GP system, you can set up a really simple search on there to say, right, whenever I've been a prescriber in the last month, what items have I issued and to who? Again, spotting those trends, seeing what you're doing, really brilliant piece of work if you're coming for revalidation. In the last 30 days, this is the prescribing that I did. In some cases, you might stretch it a bit further because then actually you might realise you're doing a lot less prescribing than you could do. So then it's the discussion of reviewing, are you doing the right clinics? Are you seeing the right patients? Or it could just be the admission going, actually, yeah, no, I don't need to. I'm giving advice, I'm giving support, I'm starting new medicines, but actually our practice is so good, I'm not doing the initiation. If you're within a hospital setting or prescribing through a hospital clinic, again, if they have electronic prescribing, it's a really good way just to try and pull that through. Again, question from Tina in the chat, how often should we be doing an audit? It depends why you're doing the audit. So if you're a GP advanced, you're working in a GP practice, you're an advanced nurse practitioner, again, you might be producing thousands. You know, there might be lots of things going on there. So actually auditing for a month might blow your mind and you're never going to be able to review that. So you might do a snapshot of the day to see whether it fits in with your formulary. You know, if you find out that you're using a lot outside of what's in your formulary or what's in your competencies or that you have evidence for, then again, that challenges you to do something. If it's tick box, yeah, I'm using all the normal medicines, I know everything that's going on, then you can move on. You've got diabetes and cardiovascular. Again, really, really simple. If you're using those as two separate, cardiovascular, usually a lot more simplistic. And again, please don't throw things at the computer when I say that. But, you know, if you're looking at those, you know, if you have a look at what areas you're prescribing, audit appropriately. So if you think a 10 patient snapshot is suitable and you see 10 patients in a morning and you can put that time to basically record that, great. If you can't, ask your IT support, ask them to run a search for what you've prescribed over the last month, what the indication was, what registers the patient were on, what medication it was, and you can go back and review. So again, it's trying to do that. What gives you confidence that you're prescribing within what you should be doing? And again, what are you avoiding? What did you spend hours writing your P formulary for, you know, moxonidine for that one patient that has that weird thing that you found in a paper once while you were doing your NMP course that you never actually use? Could you get rid of that? Why aren't you using it? You know, challenge yourself. Should that be on a P formulary? But again, it's horses for courses. If you work within a trust, you might find that you're asked to do an audit every year. And that ticks a box, that's absolutely okay. And in some cases, I've seen the audit being made up of 3 patients. Usually the last 3 patients you see after the email you had saying you need to get your results in by today. So again, that's doing an audit because you have to. It's never valuable, never ever. But actually saying, right, what questions am I going to ask myself? You know, I'd just be interested. Which patients do I see? If you're always adding on the 5th antihypertensive because everything else has failed, is that good use of your time in your clinic? You know, if you're seeing that patient for the first time and that's where your skill is in a practice, brilliant. So your audit might be, am I prescribing always the 1st antihypertensive? That's where I should be sitting. That's where my benefit is, having that education, talking to the patient, doing that background. That's where my clinic should be. So you can give that evidence for where you sit. And again, with this, that's you as personal. You're always working as part of a team, much wider teams often. So how do you look at what everybody else is using? Now, I've put a link on there for open prescribing. This doesn't allow you to drill down into what every individual in your practice is prescribing, but it gives you a flavour of what's out there. So if you know on your P formulary you've got a drug that actually you really like and no one else uses, you can go on there and see nationally from every practice in the known world. You can just look at your own practice. Do we use a lot of this? Is this just going past me? If you see a drug you think is really horrible and you keep seeing it, you can see actually what's out there. Again, speaking to your NMP lead, speaking to your CCG or your FT lead will help you with that review. What's on your formulary? What should you be using? But again, if you get in depth in this, seeing there's lots of things on there about trends for cardiovascular medicines, how you compare with other practices. If you want to go down the rabbit hole, that's there. If you don't, most people don't other than pharmacists like me, then you can carry on. And the key thing is with monitoring is discussing it. Many people get to be prescribers and turn into islands. I know what I'm doing. I close my door and I look after my patients. Actually discussing what you choose, how you choose it, what triggers you've got are always really good. And again, part of the case studies is a good idea. And lastly, check to see what the guidance out there says. You know, for reviewing, monitoring your own guidance, actually, does it fit in with what the latest is? And please don't fall into the trap of, if it is so different, saying, well, obviously the guidance is wrong. It's one of those that can start that learning. You know, most medicines aren't wrong. It's just the preference that they have in and which order. If you need more support on why your old favourite drug is no longer there, you know, what's the evidence for Flozins now being used as joint first line in many patients with diabetes? Brand new information, brand new out there. Why? Get some more information. So your CCG or FT will have guidance on there. NICE has got some lovely papers out there. Again, there's experts out there that can help. So again, if you're challenging that, having those discussions. And again, it could be that you're the front runner in your area because you're looking at this, you're doing it regularly. For somebody who's a non-specialist in that area, if you're not doing your cardiovascular or your diabetes clinic, you might not be as up to date. So again, having those discussions will help those around you as well. And just to point on that, if you're struggling, really, really simple. Google's out there now. Don't do Dr. Google. It doesn't have all the answers. And yes, everybody that's ever got a system will have cancer. That's what Google says to start off with. But if you're looking for guidance out there, how other people have translated it, if you put in whatever the area of, that you're thinking about that you want to know, pop in CCG, click on tools on Google. You can change it to UK so you're not getting any American information. You can also do the past year, meaning you're not seeing guidance from 15 years ago, and just see what other people are saying. In most areas, CCGs, GPs love plan on a page. If you can put it in a page or two, wonderful. So you get the headline information without spending 9 hours reading through the 90 pages of NICE. But you can also see how people are challenging other areas. Again, if you're within foundation trusts, you put diabetes FT, those lovely, wonderful trusts that put their guidance out there nationally, you can then find it, see what they're doing. Again, if you see a new drug, it's a great way. Put in the new drug name, put FT, CCG or NHS, you get an idea of what's happening. That can just be a nice shortcut. Again, I apologise for those people who do this all the time and I'm teaching grandmothers to suck eggs, but it's one of those useful things. And with this, going back again to the RPS framework. Using all of this, they say if you're a competent prescriber, you've got to split everything into two. So they give recommendations on your consultation skills and what needs to be part of a good consultation and what needs to be around your prescribing governance. So nothing earth-shattering there. Unfortunately, they've split it down into 75 different areas. So the 75 different statements that they say are helpful to NMPs, well, helpful to all prescribers to compare themselves against. Just some flavors of those. And again, if you wanted to do the 75 for every single consultation, you'd be seeing one patient a day. And I know that I would be asking to be sacked by all of your practice managers. So I'm not suggesting that. This is just the review and the information to go out there to challenge you, to help that monitoring. So things like do you assess the communication need of the patient and carer, and do you adapt your consultation appropriately? Yes, you will all do this. But again, it's one of those challenges to go, do I do it all the time? You know, especially when you have somebody who's, you know, Asperger's, somebody who's, you know, got any additional needs. How easy was it for you to do that? You know, when you learn some things, you know, actually this patient comes in and if they watch their video all the time, they attend with their mother, I can do whatever I need to do and they're calm, they're happy, or I need to call them in at the end of clinic because they can't deal with a full consultation room. You'll do all of these things naturally. I've seen it in all of the COVID vaccination clinics. People do this naturally. Documenting it, improving it is a great thing to do. Lots of things on there. And I realise, you know, all of these things you can look if you follow the link that's on there. But other things, when you prescribe a medicine or device, do you have up-to-date awareness of its actions, indications, dose, contraindications, interactions, cautions, and adverse effects? Now that's 1 point out of 75, and that would take most people in most medicines a lifetime. So again, it's not saying actually this has to be detailed out there, but it is saying you need to be up to date. So I go back to the diabetes discussion. You know, if you're reviewing somebody who's on dapagliflozin, are you aware that there's been an MHRA recommendation on this? Are you aware that in the last 6 months, that the recommendation of using 5 milligrams in insulin patients has been said a no-no? You know, if those things are brand new information, are you aware that this is now recommended for use in heart failure patients? Are you aware that it's now outside of diabetes recommended for use in CKD patients? So with all of that, that's just one drug that is relatively straightforward and sensible. And again, that's the change in the last 6 to 12 months. So with this, it proves right, actually, you're signing up to being a prescriber. This is what you're delivering. So part of that is, can you do it on a day-by-day basis? Absolutely not. You haven't got time and space. How are you going to put that into your common practice? So you can sign up to an MHRA alert. That could ping an email in. That's absolutely fine. You can shout at your GP and say any communications you get in about this from the CCG, from Trust, you know, you lead clinician. I need to know about these things. I need my life made easier. But also Google. Google's a great friend. You know, MHRA is one of the key things. NICE are one of the key things that develop these. Both of those are updated in your online BNF. So again, please don't put in your P formulary, I follow the BNF, and put a hyperlink to the online BNF, because that updates within a couple of days of any guidance coming in. So make sure your P formulary says this is how I use it, but review that regularly against the BNF. Just skim through. It says NICE guidance. It says safety alerts on there as well, so you can dig through those. And then you go on to other areas. As I said, once you go through these and read them in list, it's all really common sense. You'll do all of these 75s all of the time. Can you evidence them? That's a good thing to look at for your audits. But also, you know, simple things. Do you check that your patient or carer understands the discussions you've had? Everybody will say yes, but if you stop and think, right, actually, did I get that across well? Was I confident in myself? Did they leave with the right information? Really good one to look at when somebody turns up and said, and you ask them why they haven't taken their blood pressure medication for the last 12 months. And they look at you blankly and say, no, I did. I took the month that you gave me. Because then you realise that they've only ever taken antibiotics in the past. and they would never realise that actually you meant them to take them for the rest of their life. All the other prescriptions, they've taken the prescription, finished the dose, that's it, move on. Lots of examples like that. So at that point, you go back and think, oh, right, that would really help with the discussions. So starting a new medicine, people can misunderstand it. People can take it that wrong. Common sense isn't common. Wonderful, I'll move on. But all of these have that sort of feeling. So if you wanted to look at them, I'd say suggest maybe looking at section 1 first on that link and just saying, do I do that all the time? Maybe next month, have a look at section 2. Do I do this? Can I challenge myself? Again, most people leave it till revalidation time when they get called for evidence and information and putting portfolios together. We know everyone's that stretched. But again, this is designed to challenge. You can cherry pick those ones that are useful for you to ask those questions. I just put a bit more, but again, my mouth's getting dry, so I bet your ears are beginning to bleed at the moment with these. But again, section 7 is probably my key. Do you prescribe within your own scope of practice? So again, how do you show your scope of practice? And as a prescriber, it's not for somebody else to mandate for you. It's not for somebody else to evidence. It's down to you. All your guidance, the NMC, for pharmacists, their regulators, for any other prescriber, you prove that you know what you're doing when you're prescribing. And again, to me, that's the biggest difference with medical prescribing. There's due to the training, there's an idea that they have competence and you have to prove that they're not competent to try and stop them to do anything. With non-medical prescribers, it's down to you to evidence it. You've got to provide the evidence. So you've done that in a 6-month course through the university. So it's about continuing that. Actually, right, I did that study, I did those joint clinics, I did the learning, the reading around, I provided evidence. How can I take that forwards? And again, some of these go back on themselves. 7.5 there, keeping up to date with emerging safety concerns relating to prescribing. That goes back to the original point when I said, you know, are you aware of the safety issues, the indications, any problems? That links in with that. So many of these duplicate them. So it's that actually, if you know the safety of your medicine, you've put something into place to be aware of any emerging safety concerns. And again, asking your practice, how do you get it? In the book, it's CAS alerts. So there's a central alerting system. You can sign up for the e-alerts to get through to you, or your practice manager could flag it up to you. The same with your foundation trust. You can individually sign up to a CAS alert. Lots of these say, you know, you'll get one popped in today about IV medication not being appropriate. That's fine. You just filter that off. I'm never going to prescribe IV medication as an NMP in GP land, so that would go. If that's one of your bread and butter in hospital, if you're an antimicrobial pharmacist, key reading. But again, you can see those, you've got a system in place, you can evidence that you're trying. And 7.6, I know many areas talk about datixes or incident reporting. From somebody who uses that to try and change systems in my role, incident reporting and datixes are unbelievably valuable. So they do change practice, they do change systems, they do highlight that things are going wrong. And I love the ones where it's Monday morning, caps lock on. Why have I been asked to do this stupid thing? You know, why have I been asked to prescribe this thing that doesn't exist on a GP system? You know, why can't I find out what the dose is for this area? You know, why doesn't it tell me in the BNF? You know, most of it's screaming into the void, but then you go, God, yes, prescribers don't know this. They can't find the information. We need to put that information out there for them. So again, if you feel like you're screaming in the dark most of these times, stick it on an incident report, stick it on a datix, tell people, shout about it, say what you don't know. Or when you've found out after 6 months of chasing to find out the answer, share it as a learning point. I never knew this. Why did nobody tell me? Now I found it out here myself. But again, the more incident reports, the more datixes you report, the more evidence you have as a non-medical prescriber that you're taking your responsibilities appropriately. You've got that evidence there that you're linking back in the system, you're prescribing as part of a team. All of these are things out there that a prescriber that you should be doing. So answers so many different things. And the worst case scenario is if you get somebody who responds saying, actually it is in the BNF, the dose is down. If you scroll down a few more pages, you'll be able to find it. You've lost nothing. But again, you've got evidence that you've been working. and that hopefully links seamlessly. Oh, I've got 3 minutes. Scope to prescribing practice. Again, you need your knowledge and your competence. So please do look out there. If you're changing anything, employment, you will be starting again. You'll be asking new NMP lead. And if you're returning to practice, use it as a power. It's a superpower. I need to know how you use the systems. I need to know what's going on. I need to know what's expected of me. That's your day one request, your pre-day one request. Coming back from maternity leave, don't expect that you'll carry on at this challenge. If you've been asked to do a different role, we get lots of incidents where patients are writing FP10s and then go into hospital settings. No, you need training on how to use the hospital systems and vice versa. Your evidence and competencies, all of these are options out there. CPD, audits, case studies, discussing with your colleagues. You do this all the time. You'll Google stuff all the time. You'll check in the BNF. Evidence it. That's really, really powerful. Dead simple, dead straightforwards. I'll skip over key questions. Oh, no, I won't. So are you prepared to be a prescriber? That's the day one question, but it goes forwards. If things change around you, are they still good? Who do you reach out to if you're not happy with prescribing in the environment where you are? Please check that it's in your job description. Something goes west, patients on medications die. We all die. But if you're involved in this, make sure it's listed in your job description and make sure you've got insurance suitable to what you're doing. So if you're working within your job scope, you might be covered by NHS. If you go beyond your job scope, it's a challenge. Evidencing your competencies. And again, what steps are you going to take to deal with the challenges you come up with? Who do you shout? Who do you scream to? Who do you incident report? Who do you ask for help? So I've whittled on too much. There's no oxygen left in the room. So before we get dragged back into the room, is there any questions? Anything? And again,
Joel,
these slides are going out to everybody.
Yeah, and it'll be it's been recorded as well. There is one question here. It's about how long do you have to be qualified to be able to apply to be a prescriber, from Charles.
So with this, the guidance for nurses is 12 months experience in a similar role.